Stephen, my name is Dr. Varsi. Pleasure to meet you. Pleasure to meet you. You've been asked to examine your lips. That's all right. Do you have any tenderness?
No.
Just look up for me. Just stick your tongue out for me, can't you? And then, can I just get you to take a gulp of water, but just don't swallow it straight away. And look up and swallow. Okay. I'm going to have a feel of your neck if that's all right. Okay. Just look up for me. Can I just get you to take another gulp of water for me, please? Just hold it. Just look up and hold it there. And swallow for me. That's lovely. That's fine. Right, I'm just going to tap nice and gently. Just look up and hold your breath. And breathe. And look up and hold your breath. That's grand. Now just can you put your arms out for me and just turn them upwards and just hold them there for a second. Fine. Just relax them down. Okay. Just relax your arms nice and gently. No, I'm just going to take here. Steps. Thank you very much.
Thank you.
Mrs. Davis is going to be a part of your endocrine station, which is a 5-minute station again. Classically, you may be given a history of a patient who may have a thyroid goiter, and what you're trying to examine is one, whether this is a thyroid goiter or another cause of a mass in the neck, and also if it is a thyroid goiter, what type of thyroid goiter it is, and also whether the patient is euthyroid, hypothyroid or thyrotoxic. And Mrs. Davis, the classical issues here are when you look at her from the end of the bed or the chair, there are no evidence of any eye signs. There's no proptosis, which classically is best seen from above and from the side, but there is no parietal ultraedema. When you look at her, she appears comfortable, she's not twitchy, and she doesn't overtly appear myxodematous either. When you get her to stick her tongue out, you're looking for a thyroglossal cyst. There isn't one to be easily seen. Also, when you look up, you can't easily see a thyroid nodule either. When you get her to swallow, there is an appearance of a mass coming retrosternally into the neck. On palpation, there is a multilobular goiter present, so we're not looking at a smooth goiter, therefore it's unlikely to be Graves' disease, and therefore in examination I didn't look for pretibial myxedema, thyroid acropacy or Graves' eye signs. She hasn't had a thyroidectomy scar that we can see, but when you examine her neck, especially as she swallows, you feel the thyroid gland come and pass over your fingers. There is, on percussion, retrosternal extension and auscultation. There are no bruits. She's not tachycardic, and there are no slow releasing reflexes. Therefore, this lady has a multinodular goiter and she's clinically euthyroid. Mrs. Davis has a multinodular goiter and she is euthyroid. On clinical examination, the patient appeared well. There were no obvious signs of thyrotoxicosis or hypothyroidism. Her pulse was 85 and regular. On examination of the neck, on palpation, when she gulped a bit of water, you noted that the thyroid nodule extended from retrosternally past your fingers. There was also a palpable lobes on both sides. Percussion note showed that there was retrosternal extension. There were no bruits audible. She was not sweaty and otherwise appeared well. There was no evidence of previous thyroidectomy scars. Therefore, in summary, Mrs. Davis has multinodular goiter but is euthyroid currently.